first speaker for today is a Master of Science in Pharmacy with specialization in Clinical Pharmacy and Research co-instructor at the Philippine Women's University in Manila. He is also a member of the Pharmacy and Therapeutics Committee of Asian Hospital and Medical Center in Muntinlupa. And also, he is my co-lead preceptor for Hospital Pharmacy Virtual Internship Program at the Pharmacy Preceptors Guild of the Philippines. He previously worked as a chief pharmacist at the Premier Medical Center from 2014 to 2018 and assistant manager in clinical pharmacy at the Medical City from 2006 to 2014. He graduated his bachelor's degree in pharmacy at the University of the Philippines and earned his master's units in pharmacology at the College of Medicine in the same institution. He earned his master's in business administration at the Ateneo Graduate School of Business in 2011. And today, to discuss antimicrobial and antiviral use in COVID-19, let us all welcome Mr. Edward Tolentino.
Thank you for that kind introduction, and thank you for inviting me for this ICU forum. I am Edward Tolentino, and I will be discussing the antimicrobial and antiviral use in COVID-19. The objectives of my presentation are to discuss the current guidelines on the antimicrobial and antiviral treatment of COVID-19, to review the mechanism of action of antiviral agents used for the treatment of COVID-19, and describe the appropriate use of antiviral agents for COVID-19. The global pandemic of SARS-CoV-2, the causative viral pathogen of COVID-19, has driven medical researchers and scientists to action to develop antiviral agents for the treatment of COVID-19. Considering the time and cost required for coming up with new therapies, probing the existing antiviral and other drugs against SARS-CoV-2 is cost-effective. A good example is the repurposing of Remdesivir for the management of COVID-19. We define an antimicrobial agent as a general term for drugs, chemicals, or other substances that either kill or slow the growth of microbes. These include antibacterial agents, antiviral agents, antifungal agents, and antiparasitic agents, while an antiviral agent is a class of medication used specifically for treating viral infections. Given the rapidity of emerging literature, the Infectious Diseases Society of America, or IDSA, identified the need to develop living, frequently updated evidence-based guidelines to support patients, clinicians, and other healthcare professionals in their decisions about treatment and management of patients with COVID-19. We'll be focusing on the recommendations on the following antimicrobials in the IDSA guidelines. The guidelines are summarized in a tabular format based on the severity of the disease and the type of patients being treated. For hospitalized patients, the expert panel recommend against the use of hydroxychloroquine and the combination therapy of hydroxychloroquine plus azithromycin. For ambulatory care of patients with mild to moderate disease, the expert panel suggests against the use of ivermectin except in a clinical trial. while for patients that are hospitalized because of severe but non-critical disease, the expert panel also suggests against the use of ivermectin except in a clinical trial. For remdesivir, the expert panels suggests against the routine use of this drug for hospitalized patients with mild to moderate disease without the need for supplementary oxygen. But for hospitalized patients with severe but non-critical disease, the expert panel suggests the use of remdesivir. Also for hospitalized patients with critical disease. Now we'll be discussing the Philippine COVID-19 living recommendations. While there are existing international guidelines such as the IDSA guidelines that we have discussed and living systematic reviews on COVID-19, there is a need to localize the recommendations from the evidence in our setting by local experts and users and other relevant stakeholders. With the rapidly evolving science, the living guidelines development process is used wherein recommendations are switched to a living status based on the likelihood of new evidence and the importance of recommendation in healthcare policy decision making. Living systematic reviews will be maintained to provide up-to-date, evidence-based living recommendations on the treatment, diagnosis, prevention, and control of COVID-19. This living guideline is not a comprehensive guide to all practice questions and management options on COVID-19. We'll be focusing on the following antimicrobial agents based on the Philippine COVID-19 living recommendations. This is also not meant to restrict the practitioner in using sound clinical judgment and sharing the decision with the patient, and from considering other management options according to the patient's particular needs and preferences. For hydroxychloroquine and chloroquine, the expert panel recommend against the use of these medications with or without azithromycin among patients with COVID-19 infections. The expert panel also recommend against the use of azithromycin among patients with COVID-19 infections. While for ivermectin, there is insufficient evidence to recommend the use of this medication in the treatment of patients with mild to moderate COVID-19. The expert panel also suggests against the use of ivermectin for the treatment of patients with severe COVID-19 and when combined with doxycycline for the treatment of patients with COVID-19. For favipiravir, there is sufficient evidence to recommend the use of this medication among patients with COVID-19. While the expert panel recommends against the use of lopinavir and ritonavir as treatment for COVID-19 infections. The expert panel also suggests against the use of remdesivir in patients with COVID-19 infection who have oxygen saturation of greater than or equal to 94% and do not require oxygen supplementation. However, the expert panel suggests the addition of remdesivir to dexamethasone in patients with COVID-19 infection who have oxygen saturation of less than 94% and or requiring oxygen supplementation. The expert panel also suggests against the use of Remdesivir in patients with COVID-19 infection who are already on invasive mechanical ventilation or ECMO. Before we discuss the mechanism of action of antimicrobial and antiviral agents for COVID-19, let's discuss the life cycle of SARS-CoV-2 in host cells. SARS-CoV-2 primarily infects the respiratory tract, which includes the nasal epithelial cells, pneumocytes, and alveolar macrophages, and the gastrointestinal tract. The virus enters through the direct interaction between the viral S protein and the cellular receptor angiotensin converting enzyme 2. Following entry, the viral genome is released and translated into the viral replicase polyproteins PP1A and PP1AB. The viral replicase polyproteins are cleaved into functional proteins by viral proteases. Viral genome replication is mediated by the viral replication complex, including the RNA-dependent RNA polymerase or RDRP. Viral nucleocapsids are assembled from the packaged viral genomes and translated viral structural proteins. And these viral nucleocapsids are released through exocytosis. Potential targets and postulated mechanism of action for antiviral interventions are as follows. Azithromycin inhibits viral entry into the cell, while hydroxychloroquine, based on in vitro data, inhibits endosome maturation. Protease inhibitors, such as lopinavir, inhibit viral/endosome membrane fusion or viral polypeptide maturation. Nucleoside/nucleotide analogs such as remdesivir and favipiravir inhibit viral genome replication. Lastly, we will be discussing the recommended antiviral agent for COVID-19, which is remdesivir. Remdesivir is an adenosine nucleotide prodrug that is metabolized to the pharmacologically active nucleoside triphosphate metabolite after being distributed into the cell. Remdesivir is an inhibitor of SARS-CoV-2 RNA-dependent RNA polymerase or RDRP, which is essential for viral replication. Remdesivir is given for adults as a 200 mg dose on day 1 followed by 100 mg once daily dosing with a duration of 5 to 10 days. For adults with renal impairment, there is no dosage adjustment necessary for patients with eGFR greater than or equal to 30 ml per minute, while for patients with eGFR less than 30 ml per minute, the manufacturer does not recommend the use of Remdesivir. However, significant toxicity with a short duration of therapy is unlikely, and there is no formal safety or pharmacokinetic data that are available for patients with kidney impairment or who are receiving renal replacement therapies. For adult patients with hepatic impairment, there are no dosage adjustments provided in the manufacturer's labeling. While for those patients with hepatotoxicity during therapy, especially if the ALT is greater than 10 times the upper normal limit, you need to consider discontinuation of Remdesivir. While for patients with ALT elevation and signs or symptoms of liver inflammation, based on the manufacturer's labeling, they recommend to discontinue Remdesivir. The lyophilized powder formulation of Remdesivir should only be used for infants and children less than 12 years old. The dose for patients weighing 3.5 kilograms to less than 40 kilograms, the loading dose is given at 5 milligrams per kilogram per dose on day 1, followed by 2.5 milligram per kilogram per dose once daily. For patients greater than or equal to 40 kilograms in weight, the loading dose is given as 200 milligrams on day 1, followed by 100 milligrams once daily. For children greater than or equal to 12 years and adolescents with weights less than 40 kilograms, the lyophilized powder formulation of Remdesivir should only be used. And Remdesivir is given with a loading dose of 5 mg per kilogram per dose on day 1, followed by 2.5 mg per kilogram dose once daily. And for patients greater than 40 kilograms, the injection solution or the lyophilized powder formulation can be used with a loading dose of 200 milligrams on day 1, followed by 100 milligrams once daily. And the duration of treatment for pediatrics is from 5 to 10 days. For pediatric patients with renal impairment, for patients with eGFR greater than or equal to 30 ml per minute, there is no dosage adjustment recommended based on the manufacturer's labeling. While for patients with eGFR less than 30 ml per minute, use is not recommended by the manufacturer. However, significant toxicity with a short duration of therapy, for example 5 to 10 days, is unlikely. So we need to weigh benefit over risk in these select patients. And there is no formal safety or pharmacokinetic data that are available for patients with kidney impairment and who are receiving renal replacement therapy, similar to adult patients. For pediatric patients with hepatic impairment, especially for infants greater than or equal to 3.5 kilograms in weight, children, and adolescents, there are no dosage adjustments provided in the manufacturer's labeling. However, for patients with hepatotoxicity during therapy, wherein the ALT is greater than 10 times the upper normal limit and asymptomatic, we need to consider discontinuing Remdesivir. While for patients with ALT elevation and signs or symptoms of liver inflammation, it is recommended to discontinue Remdesivir. Remdesivir is available as a 100 mg lyophilized powder in vial. This must be reconstituted with sterile water for injection prior to diluting in a 100 ml or 250 ml NSS infusion bag. Remdesivir is also available as a 100 mg per 20 ml or 5 mg per ml solution in vial. This must be diluted in a 250 ml NSS infusion bag. The prepared infusion solution is stable for 24 hours at room temperature or 48 hours at refrigerated temperature. Remdesivir should be administered as an IV infusion over 30 to 120 minutes for adult and pediatric patients. Remdesivir should not be administered simultaneously with any other medication or IV solutions other than NSS. The significant adverse drug reactions from Remdesivir are as follows: bradycardia, hypotension, increased serum alanine aminotransferase, increased serum aspartate aminotransferase, and hypersensitivity reactions including anaphylaxis and infusion-related reactions. The following are the significant drug interactions with Remdesivir. Chloroquine and hydroxychloroquine may diminish the therapeutic effect of Remdesivir. And we need to avoid combination of chloroquine or hydroxychloroquine with Remdesivir. While for CYP3A4 inducers, these medications may decrease the serum concentration of Remdesivir. Therefore, we need to monitor therapy with patients receiving these medications. In summary, identifying appropriate drug treatment is important for the management of COVID-19. And pharmacists should be able to apply current guidelines and appropriate drug information on antimicrobial and antiviral agents in managing patients with COVID-19. With that, I will end my presentation and thank you for listening.